Hello everyone, I'm Dr. Chidebele Okonkwo, a medical officer at First Cardiology Consultant, and today I'll be discussing the topic management of acute coronary syndrome. I'll be discussing with this outline. To introduce the topic, acute coronary syndrome refers to a group of diseases that's characterized by reduction in blood flow to the heart, and it's due to atherosclerotic disease of the coronary arteries. Now, this disease entity, acute coronary syndrome, is classified into two broad groups: ST elevation myocardial infarction and non-ST elevation acute coronary syndrome. Now, for the second class, it is further grouped into unstable angina and non-ST elevation myocardial infarction. The basis of the disease is the formation of atherosclerotic plaque in the wall of the arteries, and this plaque contains inflammatory cells and lipids that maintain inflammation in the arterial wall. Now, this plaque is unstable and can rupture, leading to the release of thrombogenic materials into the bloodstream, and this leads to the activation of platelets and clotting factors, leading in turn to the formation of thrombus within the vessel. Now, this thrombus that is formed can cause either partial or complete occlusion of the vessel. Now, when there's a complete occlusion, it results in inevitable death and damage of the myocardial tissue, and this leads to ST elevation acute coronary syndrome or ST elevation myocardial infarction, with also release of cardiac enzymes, including troponin, into the bloodstream. Now, this causes a transmural damage to the affected area of the heart muscle. Now, for partial occlusion, it causes a non-ST elevation acute coronary syndrome, and this is because there's still some residual blood flow through the partially occluded vessel, as seen here. Now, this can cause ischemia of the myocardial tissue because there will be mismatch between the myocardial oxygen demand and the blood flow. Now, if this mismatch leads to infarction, then it is called non-ST elevation myocardial infarction. And in this case, there will be also release of cardiac enzyme into the bloodstream. Now, if this mismatch by the reduced blood flow does not lead to infarction and but causes ischemia, then it is called unstable angina. So patients with this condition will report symptoms that are unpredictable, whether at rest or during activities, and but there will be no evidence of infarction as such as release of cardiac enzymes in the bloodstream. So there are risk factors for this disease, and they are classified into modifiable and non-modifiable risk factors. Modifiable risk factors for acute coronary syndrome include smoking, high level of lipids in the blood, especially high low density lipoprotein, physical inactivity, obesity, uncontrolled diabetes, poor diet, um, taking high levels of carbohydrates and fatty food, especially processed foods, and taking less of fruits and vegetables and whole meals. Also, the consumption of alcohol in excessive amounts, the risk factor for this disease, recreational drug use, hard drugs, and psychosocial stress. For the non-modifiable risk factors, they include age. Increasing age is a risk factor, especially when there are other risk factors as well. Gender is commoner in males, however, after menopause, it tends to be commoner in females because of reduced estrogen levels. Then family history, genetics, will increase a person's risk of developing acute coronary syndrome. And race is commoner in the Western world among the Caucasians and also the Asians. However, the incidence is beginning to increase among the Black population because of the adoption of Western lifestyle, including Western diets and sedentary lifestyle. Okay, so the clinical presentation shown in this picture that the cardinal symptoms of acute coronary syndrome include central chest pain that is described as squeezing or pressure or crushing, and it tends to last more than 20 minutes and radiates to the left arm, the left shoulder, the jaw. There could also be associated symptoms including nausea, vomiting, excessive sweating, restlessness, and feeling of impending doom. There are non-specific symptoms that can occur in this disease, and they include dizziness, lightheadedness, fainting, fatigue, pain in the jaw, the neck, upper back, and palpitations or thumping in the chest, epigastric discomfort or pressure, or even burning sensation in the chest. Now, these non-specific symptoms are commoner in females, the elderly, and also in the patients with diabetes, especially polycontrolled diabetes. So the classification of acute coronary syndrome is based on symptoms, ECG changes, and the level of cardiac troponin in the blood. Now, the presence of symptoms and ST elevation on ECG will be regarded as ST elevation myocardial infarction. And in this class, we expect a rise in cardiac troponin because of the inevitable destruction or damage of myocardial tissue due to the complete occlusion of the coronary vessels. Now, for the second class, the presence of symptoms with non-ST elevation changes on ECG, including ST depression and T-wave inversion, and a rise or fall in troponin. For these patients, um, they are classified under non-ST elevation myocardial infarction. And the presence of symptoms for the third class with ST and T wave changes, including ST depression and T wave inversion, changes that are non ST elevation, with normal troponin level be regarded as unstable angina. Now, this slide shows the evolution of ST elevation myocardial infarction, and it stresses the importance of serial ECGs. So for patients who have ST elevation myocardial infarction, at the very initial stage, ECG trace may be normal as shown here. However, within minutes, we notice an hyperacute C wave, and within minutes to hours, the ST elevation becomes apparent. And within an hour to 12 hours, the R rays begin to disappear and the Q rays begin to form. And within these, other changes such as T-wave inversion become obvious. And within weeks to months, we notice recovery of the T-wave and persistence of the Q-wave. And this persistence shows irreversible damage to the heart muscle. We'll go on to talk about management, and we'll discuss this based on the most recent European Society of Cardiology and American College of Cardiology guidelines. So when a patient presents with symptoms suggestive of acute coronary syndrome, the first thing is to do a quick triage and assessment of the patient. And while doing this, a quick ECG within the first 10 minutes to be done. At the same time, the patient should be resuscitated according to the ABC protocol. Also connect the patient to continuous telemetry in order to examine the vital signs and the ECG tracing in real time. You should also have a defibrillator close by in order to use the device when indicated in case of a life-threatening arrhythmia. Now, the patient should be examined as well from head to toe. May note sweating, confusion, dyspnea, pallor, examine the pulse for the rate, the rhythm, and the volume. Also check the blood pressure in both arms. There may be hypertension, there may be hypotension. Examine respiratory parameters, check respiratory rates. Also listen to the lungs. There may be obvious rales or wheezing in the case of an acute pulmonary edema. Listen to the heart as well. You may hear murmurs that may suggest a mechanical complication of myocardial infarction. There may also be a third heart sound in case of heart failure resulting from MI or other abnormal sound like S4. Feel the abdomen for tenderness may suggest an ongoing mesenteric ischemia as a complication of MI. Feel the extremities as well and check for adequate perfusion the peripheral tissues. It's also important to examine for urine outputs to be sure that the kidneys are well perfused. While resuscitating the patient, including placing in cardiac position, giving oxygen when the SpO2 is less than 94% or SaO2 is less than 90%, it's important to also insert large bore cannula for resuscitation in case of hypotension. It's also important to take samples for necessary investigations, including serial troponins, electrolyte urea and creatinine to check the renal function, full blood count as well, and other important blood works. During this period, a brief history should be taken, and the focus should be getting the symptoms of the patient, finding out possible etiology, finding out the complications, also find out what treatment or medications the patient may have taken recently. You want to also know what the comorbidities may be, find out also about allergies, and yes, history that will help in management of the patient. Going on, within 10 minutes of presentation, a diagnosis based on ECG should be made. And the very important one to mention is ST elevation myocardial infarction. So this should be made, diagnosis should be determined within 10 minutes. And this is made based on um, ST elevation, significant ST elevation in at least two contiguous leads, as stated here, the criteria stated here. And the ECG here shows of a patient with significant ST elevation in inferior leads as shown, and reciprocal changes in the anterior leads and also the lateral leads. You can see this reciprocal ST depression, T wave inversions in the anterolateral leads. For ST elevation myocardial infarction, it's important in some patients to do an extended right-sided lead in order to exclude right ventricular infarction in patients who have or show features of inferior MI, such as these patients that I've displayed. Also, for some patients, they may need extended leads up to V9 to exclude posterior MI. And for some patients, who show ST elevation in AVR. This may indicate the presence of an occlusion in the left main coronary artery. Still on diagnosis based on ECG, there are special situations that can cloud or confound the diagnosis of ST elevation myocardial infarction. And these special situations include presence of left bundle branch block or a previous left ventricular hypertrophy. But making the diagnosis is possible based on looking at patient symptoms of a possible acute coronary syndrome and some ECG changes I'll talk about, and also change in troponin level. So for left bundle branch block, this Carbosa criteria will help making a diagnosis of ST elevation myocardial infarction in this group of patients. While for left ventricular hypertrophy, having an ST elevation that is more than 25% of the deep S waves, with presence of signs and symptoms that suggests acute coronary syndrome, and also a rise or fall in troponin levels will raise the index of suspicion for an ongoing ST elevation myocardial infarction. For the other group that is also diagnosed based on ECG within the first 10 minutes, um, it includes the non-ST elevation acute coronary syndrome. Now, for this group of patients, you will see other ST changes that are not ST elevation, and they include ST depression, as shown here, and T wave inversion, and this should be saying at least two contiguous leads. Um, Furthermore, these patients are categorized as having either very high risk or high risk. Now, those classified under the very high risk group will be those with features such as hemodynamic instability, life threatening arrhythmias, mechanical complications of myocardial infarction, and ongoing infarction of the cardiac muscle. For those under the high risk group are those with transient or intermittent ST and T wave changes, and also ongoing chest pain that is refractory to medical therapy. Once the diagnosis is made using ECG within the first 10 minutes, the decision must be made for immediate reperfusion therapy. Now, for those who are diagnosed with ST elevation myocardial infarction and non-ST elevation acute coronary syndrome with very high risk features, should have immediate reperfusion therapy within 2 hours of presentation. And why this is being prepared or organized for, um, these patients should have acute pharmacotherapy in order to reduce complications and preserve the coronary vessels and the heart muscle as well. Now, the options or the medications recommended for acute pharmacotherapy before reperfusion therapy include all of these listed here. Now, nitroglycerin is the first on the list, and it helps to offer symptomatic relief for these patients. And there are contraindications to its use, including the presence of hypotension, the suspicion of right ventricular infarction should be avoided when there is such suspicion because it can cause severe hypotension in this group of patients. Also, when there is already bradycardia or severe tachycardia, nitroglycerin should be avoided. Also, in patients who have used phosphodiesterase inhibitors in the last 24 to 48 hours, including sildenafil or tadalafil, nitroglycerin should not be offered because severe hypotension can result from that. Um, Adequate analgesia must be ensured, and IV morphine is recommended. IV morphine will also help with anxiety and also acute pulmonary edema for those who have this complication. Metoclopramide should be added in order to um, manage the adverse effects of morphine, which is nausea and vomiting. IV beta blockers, cardioselective group is recommended, and this helps to reduce the myocardial oxygen demand and in turn reduce the myocardial ischemia burden. So IV metoprolol is recommended here. The contraindications to the use of this medication include bradycardia and also the presence of hypotension. In fact, it is recommended that systolic blood pressure should be above 120 millimeters of mercury before administering the beta blocker. And this is to avoid the incidence of hypotension that can follow myocardial infarction, especially when a large part of the heart is affected. Dual antiplatelet therapy, the loading doses of these medications should be given and is to protect the coronary vessels. And the options here include aspirin plus a P2Y12 inhibitor, including clopidogrel, prasugrel, and ticagrelor. Now, PPI should be added to protect gastric mucosa, but we must remember that PPIs can reduce the efficacy of clopidogrel. This effect is not seen with the use of the other antiplatelets. Bleeding risk should be considered as well in these patients when administering antiplatelets and anticoagulants. The anticoagulant of choice is Clexane, and it is important for the similar reason to protect and preserve the coronary vessels and limit um, the ongoing thrombotic events in the coronary vessels. High intensity statins are also recommended to also preserve the coronary vessels. Angiotensin converting enzyme inhibitors are important in these patients in order to prevent cardiac remodeling, prevent the thinning of the heart, and prevent ventricular aneurysm. However, for patients who do not tolerate this medication, and or are allergic to this medication should have alternative, which is the ARBs, angiotensin receptor blockers. The diuretic should be given to patients who are in acute pulmonary edema or coming in acute heart failure, and this will help, to improve symptom and also improve oxygenation. For those who have hypotension, they should receive blood pressure support, including fluid therapy, use of inotropes, and also intra-aortic balloon pump support. The option for reperfusion therapy for this group of patients is immediate angiography, invasive angiography with primary percutaneous coronary intervention (PPCI). Now, for facilities where this intervention is not available or cannot be offered within 2 hours, now they can use the option of fibrinolysis, and the tissue plasminogen um, activator should be used, and the options include tenecteplase and alteplase. Once the reperfusion therapy is concluded, the patient will be transferred to the ICU, where there will be continuous monitoring of vital signs, ECG tracing and telemetry, and also to monitor and rule out complications and manage them immediately they are seen. Now, for patients with non-ST elevation acute coronary syndrome without very high risk features but with high risk features, should have early reperfusion therapy within 24 hours, and this is done via invasive coronary angiography with PCI, and acute pharmacotherapy should be instituted before the procedure. For patients with non-ST elevation acute coronary syndrome who do not meet the criteria for either immediate or early reperfusion therapy should be observed and should have serial high sensitivity cardiac troponin checks at 0 hour, and then a repeat at the first hour or the second hour as well. Now, for those who a rise or fall in troponin level is seen, they should be ruled in as having non-ST elevation acute coronary syndrome with high risk features and should be managed as such. For those who do not show any change, whether rise or fall in troponin, should have non-invasive coronary angiography done at a later time, and should also have further tests, including stress tests, to properly evaluate the chest pain. Further investigations are important, including other blood works such as full blood counts, as anemia that can complicate myocardial infarction. Electrolytes, including potassium, calcium, and magnesium, should be checked and deficiencies corrected. Urea and creatinine should be done, which will give a picture of renal perfusion and renal function. Lipid profile should also be done. However, the results does not determine or rule out including high intensity statins in the medications of this patient. So regardless of the results, and it's also important that um, in the acute phase of the disease, LDL can be falsely low. So high intensity statins are important regardless of lipid profile findings. Inflammatory markers are usually elevated. NT-proBNP should be done and monitored in patients who develop heart failure as a complication of MI. Chest X-ray should also be done to follow up with patients and also for patients who develop acute pulmonary edema. Echo is important to rule out mechanical complications and to check for left ventricular function. Um, for patients in whom it's difficult to tell if they have developed an apical clot with echo, a cardiac MRI can be done. Then it's important to also follow up with serial high sensitivity cardiac troponins in order to monitor patients' progress and Continuous ECG monitoring is important to check for arrhythmias. Further management. Um, for patients who have multivessel disease, surgical intervention called coronary artery bypass graft is recommended. Now, prior to this surgery being done, medical therapy should be instituted and should be optimized. Now, following PCI or surgical therapy, long-term medical therapy is indicated in order to improve function, prevent recurrence, and prevent complications. Lifestyle measures are also important, especially avoiding smoking. The goals of the long-term medical therapy include to control symptoms, to preserve the coronary vessels, to reduce the magnitude of myocardial ischemia and infarction, to reduce or prevent cardiac remodeling, to anticipate and manage complications, to manage comorbidities, and also lifestyle management. Comorbidities may include diabetes mellitus, chronic kidney disease, and this should be managed effectively. Now, for the long-term medical therapy, for patients who have residual chest pain or residual angina, nitrates as when required is important for them. And also for residual angina and blood pressure control, we in patients where it's difficult to control blood pressure, calcium channel blockers will be important. Now, dual antiplatelet therapy at maintenance dose is important also to preserve the coronary arteries. High intensity statins are also important for the same reason. Beta blockers should be continued to ensure that the myocardial oxygen demand is reduced, and also the myocardial ischemia and infarction is limited. ACE inhibitors are important to prevent cardiac remodeling. For those patients who can't tolerate ACE inhibitors, ARBs are indicated. Now, for patients who develop left ventricular dysfunction, especially a reduction in ejection fraction to less than or equal to 40%, will benefit from these medications. Now, the angiotensin receptor and neprilysin inhibitors are said to be superior in this group of patients to the ACIs and ARBs. However, where the ANI, these are not available or a patient can't afford it in low income areas, ACE inhibitors can be used. And for those who do not tolerate ACE inhibitors, either due to allergy, should be placed on ARBs. The SGLT2 inhibitors, sodium glucose transporter inhibitors, and mineralocorticoid receptor antagonists are also beneficial for these patients, and they help improve outcome and improve cardiac function in this group of patients. After 6 to 12 weeks of the acute coronary event, it's important to recheck these patients for an improvement in their left ventricular ejection fraction using echocardiography. For those who have persistent reduced ejection fraction, they should have ICD, implantable cardioverter defibrillator, inserted. And the importance of this is that it will help to reduce the risk of sudden cardiac death in these patients. Lifestyle management is important. It's important that going forward, these patients should modify their diet, and this should include limiting or reducing um, fatty foods, carbohydrate-rich foods, processed foods, and salt, high amount of salt in their diet. Foods that they're encouraged to eat include fruits, foods diets rich in fruits and vegetables, and also lean meats and whole grains. These are beneficial to these patients. Then regular exercise is important. Avoiding smoking by all means, including first hand and second hand smoking. For alcohol intake, patients who have suffered an acute coronary event are advised to avoid alcohol if they can. For those who cannot, they are advised not to go beyond or take beyond the recommended amount of 14 units per week. The complications of acute coronary syndrome include impaired contractility, which can lead to hypotension, heart failure, cardiogenic shock. This can also lead to thrombus formation within the ventricle, and there can be embolism of this thrombus, leading to stroke, acute limb ischemia, and mesenteric ischemia. So this should be looked out for. Tissue necrosis can also occur, causing mechanical complications, including papillary muscle rupture and mitral regurgitation. Ventricular wall rupture can also occur and lead to cardiac tamponade. Other complications include electrical instability leading to arrhythmias and pericardial inflammation. Now, this slide shows the timeline for the different complications of myocardial infarction. Within the first 24 hours, life-threatening arrhythmias can occur. Within the first 5 days, the structural heart complications can occur. And within the first 2 to 4 weeks following the acute event, uh, pericarditis, also called Dressler syndrome, can occur. Now, this slide shows mechanical complications and their management. Now, for these complications, surgical management is indicated, but prior to when surgery can be done, it's important that um, medical therapy is optimized in order to improve patient symptom and improve cardiac function. This slide also shows other complications and how they can be managed, including acute pulmonary edema and cardiogenic shock, and the choice of inotropes to use in the setting of cardiogenic shock. Now, it presents a case study of a patient who managed here in our facility. He was referred um, from another facility on account of um, cardinal symptoms of acute coronary syndrome of 5 hours and 30 minutes duration. He has a background history of dyslipidemia and significant cigarette smoking of about 20 pack years. When he came in on examination, he was in respiratory and painful distress. He had poor oxygen saturation despite being on oxygen. He had bibasal crepitations. He was tachycardic and had his systolic blood pressure in 110s. He also had a fourth heart sound. He was immediately resuscitated, placed in cardiac position, given oxygen, and Weiber cannula placed, and he had important blood works samples taken. Within 10 minutes of arrival, an urgent ECG was done, which showed ST elevation in the inferior leads and reciprocal changes in the anterolateral leads. Now this is his ECG that was done within 10 minutes. You can see the ST elevations in the inferior leads 2-3 AVF and the reciprocal changes in the anterolateral leads V2 all the way to V6 and lead 1 and AVM. Now, the diagnosis was made based on ECG of ST elevation myocardial infarction complicated by acute pulmonary edema. Now, troponin levels also showed a rise from 1.5 to greater than 40,000. His other investigations are as shown. Following the ECG diagnosis, he was immediately commenced on acute pharmacotherapy. Now, he received nitroglycerin, morphine, dual antiplatelets, anticoagulants, sulflexane. He also received high dose statine and IV furosemide to help with the acute pulmonary edema. Beta blockers beta blocker and other cardiac medications like the ACE inhibitors were not given because the patient didn't have the blood pressure room to take this medication. So we're going to commence them when he was more stable. After the acute pharmacotherapy, he had immediate invasive coronary angiography in less than 1 hour of arrival. Now, the cardiac catheterization showed a complete occlusion of the right coronary artery with severe stenosis of the LAD. Now, the right coronary artery was opened up by using a balloon and a stent was placed. However, the left anterior descending artery wasn't touched, and an opening it was deferred as a result of the patient becoming hemodynamically unstable during the procedure. So he went into cardiogenic shock and he had to be commenced on inotropes, IV fluids, and intra-aortic balloon pump support. He was then transferred to the ICU, um, where his vitals were monitored closely and continuously in real time. He also had continuous ECG monitoring. Fluid balance was monitored. He had an arterial blood gas check, which showed mild metabolic acidosis. He also had electrolytes checked. Echocardiography was also done for him in the ICU and showed wall motion abnormality in the right coronary artery and left anterior descending artery territories. And also showed left ventricular hypertrophy and reduced ejection fraction of 36% and reduced right ventricular systolic function. We ensured that we did serial troponins and examine him regularly to check for complications of myocardial infarction and also examine for uh, possible bleeding. Now, his ECG was repeated following the reperfusion therapy of the infarct related artery. And following this, you can see that the ST elevation in inferior leads have greatly resolved. However, you can see the presence of Q waves now in the inferior leads and also in the anterior leads as well. Now, this indicates the presence of infarcts in these areas, the Q waves appearing, and this infarct, as we know, is irreversible. There's also loss of R waves, as you can see in these leads, the three in the anterior leads. Following the reperfusion, his symptoms improved. He no longer had complaint of chest pain. He was no longer breathless. The tachycardia he had also resolved. However, patient hemodynamic status in terms of blood pressure remains suboptimal and he needed support for about 24 hours with IV fluids, inotropes, and intra-aortic balloon pump. So after about 24 hours, his hemodynamic status improved and we were able to wean him off uh, the supports, including the IV fluids, the inotropes, and the intra-aortic balloon pump. Now, his cardiac medications were gradually instituted. He's currently being worked up for staged PCI of the LED. These are his current medications: anticoagulants, dual antiplatelet therapy, high intensity statin, and ACI. Now, the plan is to add his other cardiac meds, including beta blocker, SGLT2 inhibitor, and mineralocorticoid receptor antagonist if his hemodynamic stability is maintained. At this point, his systolic blood pressure has been holding up in the hundreds and 110s without support. Now, this slide shows the poor prognostic factors and good prognostic factors for patients in MI. Um, for the poor factors, include the previous MI, old age, presence of hypotension or cardiogenic shock, and reduced ejection fraction. And the good prognostic factors include absence of post-MI angina, absence of pulmonary edema, and the absence of significant arrhythmia after the first day. In conclusion, MI is a leading cause of death and disability globally. Timely intervention, evidence-based treatment strategies, and continuous patient management are very important in improving prognosis for patients with um, acute coronary syndrome. Thank you for listening.